Welcome back to Rad Onc Smart Review, Head and Neck Edition. We are diving straight into the deep end today.
You really are.
This is episode 36, Salivary Gland 3, and we're talking perineural invasion and named nerve strategy.
It's good to be back. And frankly, this is the topic that, it really separates the casual learners from the board-ready residents.
Absolutely. In our last session, we talked about adjuvant triggers.
Yeah.
When to pull the trigger on radiation. Today, we're talking about where that radiation goes when the tumor decides to take a road trip along your nerves.
That is exactly right. Perineural invasion, PNI, it's the defining challenge of salivary gland radiation oncology. I mean, it's the reason adenoid cystic carcinoma behaves so differently from, say, mucoepidermoid.
Right.
And it's the reason these tumors can recur at the skull base years, sometimes decades later, long after everyone thought the patient was cured.
And let's be incredibly blunt here.
Right.
This is a guaranteed topic for oral boards.
Oh, 100%. Guaranteed.
If you can't talk about PNI fluently, you can't pass a head and neck oral board section, period. So let's set the stage with the case. This is a classic presentation, the kind that makes you sit up straight in your chair.
Okay, lay it out for us.
All right. We have a 58-year-old woman. She presents with adenoid cystic carcinoma of the parotid gland.
The classic histology for this problem.
Exactly. She's already undergone surgery, a total parotidectomy. But here's the kicker. She had facial nerve sacrifice.
Wow. Okay, so that immediately tells you this was serious. You don't sacrifice the facial nerve unless you absolutely have to.
No.
That implies the tumor wasn't just, sitting near the nerve. It was enveloping it. It was compromising its function to a point where sparing it was oncologically just not safe.
That's it. Her clinical history notes that she had preoperative clinical facial nerve dysfunction. So the nerve was already weak before the knife ever touched her skin.
So the disease was already causing symptoms.
Yep. And on imaging, her MRI showed enhancement along the mastoid segment of the facial nerve, tracking toward the stylomastoid foramen.
Okay, that is a critical detail. Enhancement toward the foramen. That directional vector, that's going to dictate everything we do in the contouring room.
So pathology comes back. It confirms adenoid cystic carcinoma. It confirms PNI involving the facial nerve trunk. And we have a close proximal margin at just 2 millimeters.
Ugh, 2 millimeters.
So the surgeon calls you up. They say, look, she had clinical facial nerve involvement pre-op. We saw PNI on the path. I took the nerve, but it was close. How do you handle the nerve now?
That is the million-dollar question, isn't it? How do you handle the nerve?
It is.
And before we answer that, surgeon, I want to pose 2 critical thinking questions to you, to everyone listening. If you're driving, just take a second and think about this.
Yeah.
Number 1, what is the difference between perineural invasion PNI and perineural tumor spread PNS? Are they the same thing?
Good question.
And number 2, how far do you chase this nerve? Do you stop at the foramen? Do you go all the way to the brainstem? Where's the stop sign?
Take a second. Formulate your response. You're staring at an examiner. What do you say?
While you're thinking, let's demonstrate exactly what a perfect board-level response sounds like. This is what we call the 60-second board script.
Okay.
If you're a resident, I want you to listen to the cadence, the confidence, and the specific anatomic language. This is how you answer that surgeon.
Let's hear it.
This is a 58-year-old woman with adenoid cystic carcinoma of the parotid status post-total parotidectomy with facial nerve sacrifice. She had preoperative clinical facial nerve dysfunction and MRI showing enhancement along the mastoid segment toward the stylomastoid foramen. Final pathology confirms PNI involving the facial nerve trunk with a close proximal margin at 2 millimeters. This represents both histologic perineural invasion and clinical radiographic perineural tumor spread a high-risk scenario. My approach is postoperative IMRT with nerve pathway coverage. I will extend my CTV retrograde along the facial nerve to the stylomastoid foramen. Given the preoperative imaging showing enhancement towards skull base, I will use dedicated skull base MRI to determine if coverage should extend beyond the foramen into the mastoid or tympanic segments. The high-risk tumor bed receives at least 60 gray, with the involved nerve pathway receiving intermediate dose in the range of 46 to 54 gray per ASCO guidelines. I will not add concurrent chemotherapy routinely, as this is not standard for salivary malignancies outside clinical trials.
Wow. That was comprehensive. You hit the pathology, the imaging, the anatomy, the dose, and the systemic therapy decision, all in basically one breath.
That's the goal. You have to be that efficient. But now We need to unpack that. I mean, there was a lot of density in that minute. We need to break down why that script works and the clinical reasoning behind every single one of those sentences.
Okay, let's do it. Let's start with the first challenge question you posed. Section A of our deep dive today, the critical distinction, BNI versus PNS.
Terminology matters so much here. If you use these interchangeably on boards, the examiner will, they'll stop you right there. You have to be precise because the management implications are just vastly different.
So define perineural invasion, PNI, for us. What is it exactly?
PNI is a histologic finding. This is what the pathologist sees under the microscope. That's it. They're looking at the slide and they see tumor cells in, around, or, tracking through a nerve. And this can range from something really small, like microscopic focal involvement of tiny, unnamed nerve twigs inside the tumor, all the way to extensive involvement of a major nerve trunk. But the key is, it's on the slide. The patient might not even know it's happening.
Okay, so PNI equals microscope. Got it.
Uh-huh.
What about perineural tumor spread, or PNS?
PNS is a clinical and radiographic finding. This is macroscopic. This is stuff you can see or that the patient can feel.
So symptoms.
Symptoms, exactly. This is the patient telling you, my cheek is numb, or I can't move my eyebrow, or it's the radiologist calling you up and saying, hey, the facial nerve is lighting up like a Christmas tree on the MRI, or the foramen, the hole in the skull, it's getting wider.
So PNS implies a volume of disease that's just orders of magnitude bigger.
Thousands, if not millions of times greater than microscopic PNI. And that distinction is huge because it dictates how aggressively we have to treat, right?
It has to.
Exactly. You can't treat a microscopic finding the same way you treat gross disease tracking into the skull base.
Yeah.
If you treat every tiny microscopic PNI as if it were gross skull base disease, you are going to radiate the brainstem and cochlea of patients who just don't need it.
So how do we organize this? Is there a framework?
There is. We use the Baxt framework for management. It's really helpful. It breaks this down into 4 clear categories.
Okay, let's walk through the 4 buckets. Bucket number 1.
Bucket 1 is microscopic focal intratumoral PNI. This is by far the most common scenario you're going to see. The path report says, focal PNI noted in small, unnamed nerves.
And the keywords there are focal and unnamed.
And intratumoral. It's inside the tumor bed. The nerve isn't anything you can name. It's just a small branch.
And the treatment for that?
Treat the tumor bed, 50 to 60 gray, depending on margins. You do not need to chase ghosts to the skull base for a tiny, unnamed nerve inside the gross tumor volume. The risk of that tumor having skipped all the way to the brainstem is just negligible compared to the toxicity of treating that whole path.
Okay, that's bucket 1. What's bucket 2?
Bucket 2 is where the risk really escalates. This is large caliber, named nerve, extratumoral, or multifocal PNI.
So now we're talking about a nerve we can actually point to on a diagram.
Exactly. A recognizable nerve like a branch of the facial nerve or maybe the auriculotemporal nerve. Or it's tumor that's tracking out of the main mass along a nerve, or PNI that's seen in multiple different spots on the slide.
And this feels like we need to do more than just the bed.
Correct. Here, you extend your CTV along that nerve pathway, you chase it back toward the skull base. The dose is typically elective or intermediate. We're talking 46 to 54 gray per ASCO guidelines.
So you're sterilizing the highway.
That's the perfect analogy. You're sterilizing the highway because you suspect microscopic cells might have started the journey.
Okay. Bucket 3.
Positive margin along the nerve. This is very specific. The tumor was cut across a nerve. The surgeon says, I see the nerve stump, and the pathology report says tumor is right at the ink.
Oh, that sounds very high risk.
It is. So you cover the pathway to the skull base for sure, but now you need a higher dose to that pathway. You're looking at 60 to 66 gray.
Why the higher dose?
Because you have residual microscopic disease at the cut end. You aren't just sterilizing an at-risk area anymore. You are treating likely residual tumor.
Makes sense. And finally, bucket 4.
Clinical or radiographic PNS. This is our case today. This is symptoms or imaging findings.
This isn't the warning sign anymore. This is the actual fire.
That's it. So you cover to the skull base. And crucially, if the imaging shows proximal involvement, meaning it's already at the foramen, you have to extend beyond the foramen. You have to chase it into the bone.
And the dose.
At least 60 grays, and you escalate for gross disease. If you see a lump of tumor on the nerve on that MRI, you're treating that lump to curative doses, maybe even 70 grays if it's safe.
Now, does the type of cancer, the histology, change how we apply this framework?
Oh, it absolutely does. And this is where adenoid cystic carcinoma, or ACC, becomes the villain of the story.
Right.
ACC is the paradigm of neurotropism.
Neurotropism.
Yeah.
That means it has an affinity for nerves, it likes
It
nerves.
loves nerves, it tracks along these perineural spaces, and here's the scary part. It can skip along a nerve. It can leave healthy tissue in between and then show up centimeters away.
Wow.
That is why, even if the PNI looks focal on pathology, if it's adenoid cystic, you must have a very low threshold to cover the pathways.
So if I have a mucoepidermoid carcinoma with a tiny bit of PNI, I might, relax a little. But if it's adenoid cystic,
You worry, you have to worry. The ASCO guidelines, they say nerve coverage may be offered, but I mean, any experienced head and neck radiation oncologist will tell you. For ACC, we almost always include the pathway if there's any sign of nerve involvement. The biology just dictates that aggression.
what about some of the other histologies,
Yeah.
like salivary duct carcinoma?
Also very aggressive. It behaves a lot like high-grade ductal carcinoma of the breast, but, in the face. You treat PNI with a similar level of concern as ACC. It moves fast, and it moves aggressively.
Okay, on the other end of the spectrum, the lower risk ones, mucoepidermoid, Pacinic cell.
Generally, they have lower PNI rates. If it's a low-grade mucoepidermoid with just microscopic focal PNI in a small nerve, skull base extension is probably overkill. You just treat the bed. The biology doesn't support the same level of skip lesion risk that ACC does.
Okay, this is great. So we know when to chase the nerve, now we need to know where to chase it. Which brings us to section B, the named nerve highways.
Yes, this is salivary-centric anatomy. You cannot plan these cases if you don't know your foramina. There are big three relationships you basically need to memorize.
The big three.
When you sit down to contour, you should be able to visualize these lines on the patient's face and skull.
Let's start with the big one for parotid tumors, cranial nerve 7, the facial nerve.
Right. The one everyone worries about. It exits the skull via the stylomastoid foramen. That is your primary landmark. If you're treating a parotid, you are always finding the stylomastoid foramen on the planning CT.
But the nerve doesn't just, magically appear there. It has a journey inside the bone, right?
It does. And you need to know the segments, because if you have to track it retrograde backwards towards the brain, you need to know where it's going.
Okay, walk us through it.
So it comes up from the stylomastoid foramen through the mastoid segment. That's the vertical part. Then it takes a sharp turn into the tympanic segment, running posteriorly beneath the horizontal semicircular canal. And then finally you have the labyrinthine segment, which heads toward the geniculate ganglion.
That's a lot of detail. Do we contour all of that every single time?
Oh, no, God, no. Only if the disease demands it. But you need to know that the labyrinthine segment is where the greater superficial petrosal nerve, the GSPN, branches off.
And why is that important?
It's a junction point. That'll be very important later when we talk about traps.
Okay, noted. Big nerve number 2, cranial nerve V2, the maxillary division of the trigeminal.
This one passes through the foramen rotundum.
And why is this relevant for salivary glands? I mean, this feels more like a sinus cancer nerve.
You'd think so, but it's critical for hard palate and minor salivary gland tumors. If you have an adenoid cystic of the hard palate, it is sitting right underneath all those maxillary nerve branches.
And ACC loves nerves.
So it loves to jump onto V2. From there, it tracks back to a place called the pterygopalatine fossa, or PPF.
The PPF, it's like Grand Central Station for nerves, isn't it?
It is the critical intersection, and here is the key connection you absolutely must know for boards. The PPF contains the Vidian canal, and the Vidian nerve connects V2 to cranial nerve 7.
Wait, slow down. V2 connects to 7. How?
Yes. Through the Vidian canal and that GSPN we just mentioned. This means a tumor on the hard palate can travel up V2, cross over this little bridge, and invade the facial nerve.
That is incredible.
We see this. It is a classic board trap. A patient presents with a palate tumor and facial weakness, and everyone's confused because the tumor isn't anywhere near the parotid. But the tumor took the back roads right through the skull base to hit the facial nerve from the inside.
Like a secret subway system. Okay, big nerve number 3, cranial nerve V3, the mandibular division.
This one passes through foramen ovale, and this is your go-to nerve for submandibular gland tumors or oral cavity cancers that are spreading along the inferior alveolar or lingual nerves. If you see perineural spread on the mandible, you're tracking it back to ovale.
And just for completion's sake, V1.
The ophthalmic division. That passes through the superior orbital fissure, usually more relevant for cutaneous SCC of the forehead or scalp, but it's good to keep in your mental map.
Okay, we've got the definitions, we've got the highways. Let's put it together now into a decision tree. Section C. The if and risk ladder for nerve coverage. I love these ladders. They really simplify the chaos.
Yeah, let's make it clean so you can recall it under pressure.
Okay. If you have clinical PNSO, symptoms, or imaging findings.
Then you extend the CTV to the skull base, specifically to that associated foramen. And this is key. If there is proximal involvement on imaging, you go beyond the foramen. You chase it until you're clear.
Got it. Okay, next rung. If pathology shows a named nerve, a large caliber nerve, extratumoral extension, or multifocal PNI.
Then you extend the CTV along the pathway toward the foramen. You treat the highway. Simple as that.
Okay. If it's adenoid cystic carcinoma with any PNI at all,
then you strongly consider coverage to the skull base. The biology, that neurotropism, it scares us into being aggressive. You have to assume the tumor is smarter than the microscope.
good rule of thumb. And finally, if you only have microscopic focal intratumoral PNI and small unnamed nerves, and it's not a neurotropic histology.
Then your tumor bed coverage is likely sufficient. Don't overtreat. I mean, the toxicity of skull-based radiation, hearing loss, temporal lobe necrosis, it just isn't worth it for a low-risk scenario like that.
That is a really solid practical framework. Now, we gave a script earlier for our specific case, but now I want the general script, the named nerve PNI board script. This is what you say when the examiner asks, what is your general strategy for nerve involvement in salivary cancer?
Okay, this is the one to memorize. This paragraph covers all the bases. Ready?
Let's have it.
In salivary malignancies with perineural invasion, especially named nerve involvement or clinical radiographic perineural tumor spread, I extend coverage retrograde along the involved nerve toward the skull base, typically to the associated foramen. I use dedicated skull base MRI with thin section post-contrast T, 1 fat-suppressed imaging to map the extent of disease. I track to the foramen by default, and I extend beyond the foramen into Meckel's cave for trigeminal branches or into the intratemporal segments for the facial nerve, only when imaging or symptoms indicate proximal spread. For adenoid cystic carcinoma, I have a low threshold to include involved or at-risk named nerve pathways given the neurotropic behavior of this histology. The elective or intermediate dose to nerve pathways is typically 46 to 54 Gray per ASPO guidelines, with the high-risk tumor bed receiving at least 60 Grays. For salivary cancers, concurrent chemotherapy is not routine outside a clinical trial. This is per ASCO guidelines, which explicitly state that concurrent chemotherapy may not be routinely offered outside a clinical trial for salivary gland malignancies.
Perfect. I want to highlight one specific phrase you used in there because it's so important. MRI with thin section post-contrast, T1 fat-suppressed imaging. Why is the fat-suppressed part so critical?
This is a crucial technical detail that gets missed all the time. On a standard T1 sequence, fat is bright. It's white. Nerve enhancement is also bright.
Okay.
So if you have a bright nerve running through bright fat in the skull base, you can't see it. It's camouflaged. It's like trying to find a polar bear in a snowstorm.
Okay.
You use fat suppression or fat saturation to turn the background fat dark, basically black. Then the enhancing nerve it pops out like a beacon. If you order the wrong MRI, you will miss the PNS. You absolutely have to specify fat suppressed.
That's a huge burl right there.
Yeah.
Now let's hit section E, the chemotherapy decision. You mentioned it in the script, but I think we need to be really emphatic about this.
We have to be, because residents get this wrong constantly. In head and neck squamous cell, tonsil cancer, tongue cancer, we use cisplatin all the time. For positive margins, for ENE, it's a reflex.
Right. A positive margin means chemo.
But salivary gland cancer is not squamous cell carcinoma. The biology is completely different. The response to chemo is different. The ASCO guidelines are really hard on this. Concurrent chemotherapy is not routinely offered outside of a clinical trial.
So the evidence just isn't there.
It isn't there to support a survival benefit, but the toxicity is absolutely guaranteed.
So if you're in an oral board and you see positive margins on an adenoid cystic case, and you say, I'm adding cisplatin.
You're wrong. You've just failed that question. Unless you explicitly frame it as, on a clinical trial like RTOG 1008, or in a highly selected case with multidisciplinary discussion, the standard answer is, I do not add chemotherapy. Put the cisplatin down.
Excellent. Okay, let's bring all this theory back to our patient, the clinical decision points.
All right. The 58-year-old woman, ACC parotid, facial nerve sacrificed, TNS tracking to the stylomastoid foramen.
What's the definitive plan?
It's comprehensive postoperative IMRT. We treat the high-risk bed, which includes the parotid bed, and that sacrificed nerve stump to 60 to 66 gray. We have to treat that stump aggressively because we know the surgeon cut through tumor right there.
Okay, and what about the nerve pathway itself?
We track it retrograde. We go backwards along the facial nerve canal to the stylomastoid foramen. Now, because her MRI showed enhancement toward the foramen, I'm going to look very, very closely at that dedicated skull base MRI.
Right.
If the enhancement stops at the foramen, I treat to the foramen. But if I see enhancement actually entering the mastoid segment, I have to chase it up. I'm looking for the stop sign.
And the dose for that pathway?
Well, if it's just microscopic risk, so elective coverage,
Yeah.
we use 46 to 54 gray. But if there's gross disease left behind or strong enhancement inside the bone, we have to treat it as gross disease, so 60 gray or even higher.
And chemo, just to be sure.
None, not standard.
Clear.
Yeah.
Concise. Defensible. Love it. Now, let's talk about the landmines, the oral board traps. We've identified exactly 3 big ones. Trap number 1.
Trap 1. Confusing PNI with PNS.
And why is this such a trap?
Because if you treat every single case of microscopic focal PNI as if it's gross skull-based disease, you are just. You're overtreating patients. You're shooting radiation at the brainstem for a tiny nerve twig in the parotid tail.
You're causing toxicity for no reason.
Exactly. You're risking hearing loss and osteoradionecrosis for no proven benefit. The fix is to distinguish. Microscopic focal intratumoral PNI gets bed coverage. Large caliber, named extratumoral PNI gets skull-base coverage. You have to know the difference.
Okay. Trap number 2.
Trap 2. Failing to consider the V2 to CN7 interconnection.
This is the hard palate scenario we talked about.
Right, you've got a hard palate tumor. PNS is involving V2. So you track V2 back to the pterygopalatine fossa. Great, you feel good about yourself. But if you stop there, you might completely miss the tumor crossing over to the facial nerve via the Vidian canal.
So what's the fix?
If your imaging shows enhancement in the PPF, you must check the Vidian canal and the GSPN pathway to cranial nerve 7. You have to. It's an escape route. It's the back door to the facial nerve.
All right, trap number 3.
Trap 3. Adding concurrent chemotherapy for salivary gland PNI.
We've beaten this drum, but let's beat it one more time.
It is the ultimate reflex error. You see positive margin or high risk, and your brain just screams, cisplatin, you have to stop. ASCO says chemotherapy may not be routinely offered. Do not reflexively add it.
Got it. Okay, moving on to board pearls. These are the nuggets, the things you just have to hold on to.
Pearl 1. PNI is histologic. PNS is clinical radiographic. The management is different.
Pearl 2, the salivary nerve map. CN7 goes to stylomastoid foramen. V2 goes to foramen rotundum. V3 goes to foramen oval. Know it cold.
Pearl 3. The stop point rule. You track to the foramen by default. You only go beyond it if imaging or symptoms indicate proximal spread.
Pearl 4. The ASCO dose framework. Elective nerve pathway is 46 to 54 gray. High-risk bed is at least 60 grays, and you escalate for any gross disease.
Pearl 5. The MRI protocol. Thin section post-contrast T1 with fat suppression is the absolute gold standard. Insist on it.
And Pearl 6. The salivary chemo rule. It is not routine outside of trials. This is different from head and neck squamous cell.
Those pearls right there. That's your safety net.
Okay, let's test that safety net. It is time for the board blitz. 3 rapid-fire questions to see if you were paying attention.
All right, I'm ready.
Question 1. You have a 55-year-old woman. Parotid adenoid cystic carcinoma. T2N0. Cribriform pattern. The path report says, and I quote, focal PNI involving small unnamed nerves. Her facial nerve is totally intact. MRI is clear. How do you approach the facial nerve pathway?
I do not track to the skull base.
And your reasoning?
This is a classic example of microscopic, focal, intratumoral PNI in small, unnamed nerves. Even though it is ACC, if the nerve involvement is not extensive, not a named nerve, and not extratumoral, and the imaging is totally clear, you just treat the tumor bed. Chasing the skull base here is unnecessary toxicity.
Perfect. Question 2. The contrast case. This is head and neck squamous cell carcinoma, oral tongue. Pathology shows extensive PNI involving the lingual nerve, that's a branch of V3, with a positive margin at the nerve cut end. What is your CTV approach?
Okay, so I cover the tongue bed, I track V3 retrograde to the foramen oval, and a D I add concurrent cisplatin-based chemoradiation.
Why the change in chemo? Why add it here?
Because this is squamous cell, not salivary. In HNSCC, a positive margin is a hard trigger for concurrent chemotherapy. That's based on the big randomized trials, Cooper and Bernier. This question is all about highlighting the critical difference between the two disease sites.
Love it. Okay, last one. Question 3. You have a minor salivary ACC of the hard palate. MRI shows V2 enhancement in the pterygopalatine fossa, and it extends all the way to the foramen rotundum. What additional anatomic pathway must be considered?
The Vidian canal and the GSPN, the greater superficial petrosal nerve.
And why?
Because V2 connects to CN7 via that Vidian canal. If the PPF is involved, the tumor can and often will cross over to the facial nerve. You absolutely have to check that connection.
Fantastic. That brings us to the end of our session on salivary gland perineural invasion. Let's just quickly recap the main takeaways.
Okay. PNI is histologic. PNS is radiographic. Your management depends entirely on the extent focal and unnamed stays in the bed. Large, named, or ACC goes to the skull base.
Your default stop point is the foramen.
Unless you see proximal spread on imaging. And finally, keep the chemotherapy on the shelf unless you are on a clinical trial.
This was episode 36. Next time, in episode 37, we're going to tackle the really tough stuff. Unresectable disease, definitive radiation therapy, distant metastases to the lung, and all the systemic options like androgen deprivation and targeted therapies.
Yeah, that's going to be a heavy one, but it's crucial for those advanced stage 4 cases.
Absolutely. Before we go, here's a final provocative thought for you to chew on. We talked a lot today about tracking retrograde, so backwards toward the brain. But what about anterograde spread?
Interesting.
If a nerve is involved, could the tumor shoot forward along the nerve branches, out into the face, or deeper into the tongue? Think about how that might change how you define your distal margins.
That's a great point to think about for next time.
As always, go complete your practice oral boards at radonsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks so much for tuning in.